Welcome to Medical Monday.
What is Medical Monday?
Yeah, it's Club National Underground Thunder bounce when I stop the ground. Like a million elephants, a silverback orangutan. You can't stop a train. Who wants some? Don't come unprepared. I'll be there.
No, Mom, I mean, things are going great. Yeah, Medical Monday is a hit. Dr. Richmond loves it. He even said he thought I should be the medical director. It's crazy, right? Yeah, no, I don't know if they're gonna change the name to Buckstar or not. It'd be really flattering if they did. Yeah, we'll just have to see. Hey, Mom, gotta let you go. I'll call you back soon. Love you too. Bye. Hey, everybody. I don't know how much of that you heard. I was just talking to my mom. She loves her baby boy. It must be Monday. Medical Monday. Yeah, that's right. Alright, so what are we going to talk about today? Ooh, I know. Calcium channel blocker overdoses. So, the reason that these are important is because they are quickly becoming some of the most commonly prescribed cardiac medications that we see. And they have a narrow therapeutic range, meaning they can go from helpful to harmful pretty easily. A lot of them are sustained release, so this all kind of combines into increased risk, and what we're seeing is an increased incidence of calcium channel blocker toxicity. So we're going to talk a little bit about it. They can be challenging to manage, and so we'll talk about some of the management there. There's 3 types of calcium channel blockers, and I'm not even going to try to pronounce what they are, the classes, but we see the common ones we run into here. Verapamil belongs to a class that's probably the most dangerous. This has the most effect on your heart and your circulatory system, so at high doses, this can be the most dangerous one that you'll deal with. The second class, again, I'm not going to try to pronounce it. Nifedipine, amlodipine are some of the common ones we see. These more impact the circulatory system, as does diltiazem, usually more impacts the circulatory system. We're probably going to manage these all sort of the same way, but there may be some subtle differences in the way we approach this. When we look at sort of the profound effects of it, or somebody that's really crashing, what do we do? Typically, they'll first present with some weakness, dizziness. This can quickly progress to bradycardia, hypotension, and hemodynamic collapse. Calcium channel blockers often get lumped in with beta blockers, and probably the best way to tell the difference is mental status. Calcium channel blockers are not going to cause altered mental status usually. Also their blood sugar, so typically with beta blockers you'll see hypoglycemic patients. With calcium channel blockers you'll see hyperglycemic patients. With most toxicology cases you're going to be dealing with multiple substances. So always keep that in mind when you're sort of doing your assessment and trying to narrow down what you want to do. So what do we do with our patient? They're profoundly hypotensive or bradycardic. How do we approach management of that patient? So first of all, we always start with our ABCs, obviously. Make sure we have a patent airway, make sure we're breathing good. Typically circulation is going to be our issue. So first thing we're probably going to be doing is giving them fluids if they're hypotensive, and that's fine, but understand that that's probably not going to fix the problem. That'll give you a little preload, which is good, but it's not going to fix anything. So second line, I think, with calcium channel blocker overdoses is obviously calcium. Again, the treatment here may not fix the problem. It may not change much. So just be aware of that. Don't expect it to fix everything, because it might not. We give a gram of calcium, a slow IV push, typically over 5 minutes or so. And so we started our fluids, we've given some calcium, still not having much effect. Usually, on most patients, if they're still profoundly bradycardic, we would pace them. and pacing may be extremely difficult because of what calcium channel blockers do. Hopefully if you've given calcium, maybe that's better, maybe you can get capture. What a lot of people agree upon is that you need to be pretty aggressive with pressors. The question would be, which vasopressor do you use, or which blood pressure medicine do you use? Well, if we look at our shock hypotension protocol, if suspected anaphylaxis, anaphylactic shock, or symptomatic bradycardia, we start an epi-drip. If suspected etiology of shock unresponsive, so any other etiology of shock, unresponsive to fluid, we would start norepi. So I think in most cases you're safe with just going with the Levophed. The exception being if they're just profoundly bradycardic, I think it's okay to start the epi then. I think in most other cases we'll start with this Levophed, and we want to be pretty aggressive with it. So, you know, as soon as we've given our fluids, we got our calcium on board, we haven't seen much of a change, we're going to go ahead and move to this Levophed step and start giving them Levophed. A lot of times they require some high dosage Levophed or epi. You may have to call and get additional orders for an increased dose, whatever the case may be. As always, if you need our help, if you get in one of these cases and it's become difficult to manage, you can always call the OLPG line. We'll be happy to help you out. And that's it. See you next week. Have a good one. Thanks for watching.
I ain't happy, I'm feeling glad I got sunshine in a bag. I'm useless, but not for long, the future is coming on. I ain't happy, I'm feeling glad I got sunshine in a bag. I'm useless, but not for long, the future is coming on. It's coming on, it's coming on, it's coming on, it's coming on.
Finally, someone let me out of my cage. Now, time for me is nothing, cause I'm counting no A's. Nah, I couldn't be there. Nah, you shouldn't be scared. I'm good at repairs, and I'm under each snare. Intangible, bet you didn't think, so I command you to. Panoramic view.